That's all Thai. Finished. Everything else, English. So, what happened? Came from Lubbock, Texas, and my luggage is somewhere between Lubbock, Dallas, Texas, Paris, France, Bangkok, Thailand. It's not in Chiang Mai. So I went out and got traditional Thai shirt, I think, thanks to Dr. Samkit. So I apologize for not having a more formal dress, but didn't get here. So we will go on with this. But hopefully the tie will not be necessary. Tie, like tie. Hopefully the pharmacology will be appropriate. Now, I have maybe an hour and a half to talk to you about pharmacology, so we probably won't get through all the slides, but you have, yes? You have the slides. So I will talk, and whenever we run out of time, I think when you all get hungry for lunch, just do this one, and we'll stop, okay? All right, so let's start. Now, one other thing. Everybody has the little zapper, this one. Please use it, because I notice on the other slide 196 zappers machines, but maybe only 44, 50 people. You cannot make a mistake on this one. If you miss it, it's good, because then we can explain. When you take the exams, if you don't know, it's better to guess. Dr. Burke yesterday talked to you about taking the USMLE, and one of my slides says, do not fight the exam. And Dr. Burke said he didn't know what I meant by that. What I mean is, many times what you want to do is you want to find the answers you know and pick them, and don't worry. If you see a question and you don't know it and you don't understand the question, guess and go. Because some questions are not good, okay? Or some questions you don't know. But if you spend too much time for any question, you waste your time on others. There are 50 questions in a block, hundreds of questions that you take. You want to see the questions you know the answer to and move on. Don't waste time. You know, if you look at a question, you say, I'd never heard of this before ever. Move on. Pick C. Move on, because that's as close to the right answer as you're going to get. I have two daughters who are resident physicians. One is in emergency medicine, internal medicine. Other one is internal medicine, oncology. Daughter number one, no problem. She says, I don't care. Reads question, don't know, C. Moves on. Other daughter looks at questions, she says, I don't know. What happened? What don't I know? Why don't I know this? How come? Maybe. No. Pick C. Move on. Because you can't think of it, you know, if you don't understand it, move on. Because if you spend average for the questions, 1.2 minutes. Yeah? 1.2 minutes. At 1.3 minutes, C, move on. Okay? Don't waste time, because what happens is if you waste time on the question you do not understand, then you run out of time later. And maybe questions that you know are later. So don't waste time on questions you don't know. However, today, we'll waste time. Okay? And if you don't know, C. And then we'll talk about the right answer. Okay, let's see. First off, whenever you take USMLE, you can sign up. Okay? When you register for the USMLE, they will give you, this is from the website, and they will tell you different aspects that you need to know. Wait a minute. There we go. Okay, so this one is, to begin with, for us, pharmacokinetics, pharmacodynamics. And these are different areas that you should be familiar with. In other words, these are areas that may be questioned on the exam. So we'll do some for general pharmacology first. Okay, first off, I know you don't like this, but you could get asked a question. Henderson-Hasselbalch. Do you remember that? Acid-base, weak acid, weak base, absorption for a weak acid, protonated form, okay, hydrogen ion, weak acid, neutral. Neutral, non-charged is lipophilic, absorb. All right? For weak bases, the protonated form, proton, charged. Does not cross membranes, okay? So only neutral form can cross membranes. Only the neutral form can be absorbed. So we always have to wonder, what is the pH between the two barriers? In the stomach, pH is acidic. In the plasma, pH is neutral, all right? So we have to know what the difference is between those two, and the Henderson-Hasselbalch helps us to calculate that equation. Okay, so the first question. Aspirin is a weak organic acid with a pKa of 3.5. pKa. Somewhere long ago, yeah? pKa, all right? Do you know pKa? pKa means that at the pKa for aspirin, 3.5, when the pH is 3.5, 50% protonated, 50% not protonated. Therefore, for a weak acid, 50% protonated, charged or neutral? Charged, not charged. Ionized, not ionized. You know? For a weak acid, protonated is non-ionized. Therefore, will absorb. Okay? So, pKa, the pH at which the drug is 50% ionized, 50% non-ionized. Okay? What percentage of a given dose will be lipid soluble? Lipid soluble, for us, lipid soluble means non-ionized. Weak base, weak acid, doesn't matter. Non-ionized, lipid soluble is absorbed. So, what percentage of a given dose will be lipid soluble form at a pH of 2.5? At 3.5, weak acid, 50% neutral, 50% unionized, 50% ionized. In acid, more proton, more protonated. So, which guess? Let's go ahead and take your zapper and see what you think. Answer question, okay? No. More. Oh, not C. Not this one, not C. Need some more? Okay. All right. Now, I don't know if there are 196 people in the room, but only 50 people answered. Problem. Okay. You gotta, if everybody guesses, even if you don't know the answer, push a button, but not C. Well, but this was a good guess. Answer is 90%, okay? So, good. All right. I think you know this one. We'll quickly move on to it. Here is Henderson-Hasselbalch, the equation. I'm going to give you some equations, maybe 4 equations you should just maybe memorize, and then just to know. pKa is minus pH is the log of the protonated or hydrogenated form over the unprotonated. Whether it's weak acid, weak base, doesn't matter. 3.5 minus 2.5 is 1. You take the antilog of 1, and that is 10. So the ratio of protonated to unprotonated in an acid environment was 10 to 1. So if they ask you the ratio, that is the answer. The ratio of the protonated to the unprotonated is 10 to 1. Therefore, 10 times more absorbable in the stomach. However, the question was percent. And so then you have to do the percent protonated acid divided by the total. So 10 plus 1, 90%. Okay? Sorry about that. You'll never use that probably practicing medicine. But you will get a question in the step 1. Okay, 3-year-olds brought to the emergency room after ingesting an overdose of promethazine antihistamine. Promethazine is a weak base. Okay, when you hear weak base, that tells you proton charged, no proton, no charge, unionized. On physical exam, heart rate is 100, blood pressure is 110/60, respiration is 20. In the case of promethazine overdose, which of these would be the correct answer? First, urinary excretion can be accelerated by administration of ammonium chloride. Urinary excretion would be accelerated by bicarbonate, sodium bicarb. More drug will be ionized in the blood than the stomach. Remember, blood is about 7, stomach is about 2. Absorption of the drug will be greater from the stomach than the small intestines. Stomach is 2, small intestines, more basic. Weak base, the drug will preferentially sequester into the brain rather than the tubules. So let's take your zapper and see which one you like. You ready to answer? Oh. Again, same number. See? No. That's okay. Okay, now, only 20% are playing. Tells me that 75% are sleeping or don't care. All right. That's correct. Okay. Let's move on. I will let you can look at this. You can look at these answers later. Whoops. Okay. Maybe I'm going too fast here. Okay, these are the other 3 equations that I would like you to remember. The first equation is the volume of distribution. Again, you probably never need this, but the volume of distribution gives you an example of how to calculate a loading dose of a drug. And the reason for that is when you give a loading dose of a drug, you have to fill up whatever the volume is. Did I do that? Okay. When you give a loading dose, you must fill up the volume of distribution for the drug. A maintenance dose for first order kinetics. You remember first order kinetics long ago? First order kinetics for drugs is very, very important because it's because of first order kinetics that we can calculate when we will get steady state in the plasma. Steady state in the plasma is when the rate of administration equals the rate of elimination. Therefore, for a maintenance dose, you take the elimination rate is equal to a constant times the plasma concentration you wish times the volume of distribution. Or, more friendly, the clearance is equal to the elimination rate divided by the concentration that you wish to have. So you will get questions, which we'll go over, asking you to calculate the maintenance or loading dose. You should remember this dose, this equation, and remember this equation. Loading dose, maintenance dose, and then, of course, the half-life. And for a half-life, it's very important because the half-life is the time it takes to lose one half of the drug. For instance, amiodarone, you're familiar with amiodarone? Cardiac antiarrhythmic drug. Half-life is 30 days. Okay? So, if you give someone amiodarone, how long would it take to get rid of all the drug? 4 to 5 half-lives? So 4 to 5 months to get rid of all the drug. Okay? Shorter half-lives always. If it has a half-life of 2 hours, how long does it take to get rid of all the drug? 4 to 5 half-lives. So 8 to 10 hours. Okay? The principle, though, is very important because the body will eliminate half of the drug, large amounts, small amounts, in whatever that half-life is. So it's a percent elimination. Okay, let's see if we can do this one. A 70-kilogram man with heart disease requires immediate treatment with procainamide. Procainamide is an older antiarrhythmic, not used too much anymore, not as much as it used to be, but you may still see it pop up on various exams. Pharmacokinetic values for procainamide in a 70-kilogram person. Now, 70 kilograms is kind of the standard, but I have not been 70 kilograms since I was 8 years old. So I'm not 70 anymore, but normal person, 70 kilograms. Volume of distribution is 130 liters. Clearance is 36 liters per hour. Important to remember that clearance is the volume of blood cleared of drug over some time period. Bioavailability is 83%, and the therapeutic concentration that is desired is 5 milligrams per liter. That's established as therapeutic dose. So, what intravenous loading dose should be administered? What you'll need to answer this question would be that volume of distribution. So, go ahead. Answer this one now, and then we'll look at how to do it. Okay, you don't like this question. Put C if you don't know. It's okay. All right, let's see what the answer is. E. Good. All right, loading dose. And I will let you look at this one. We need a loading dose to fill up the volume of distribution. So the loading dose is equal to the plasma concentration that you desire times the loading dose, times the volume of distribution. Okay, next one, 70 kilogram man. Now we're going to calculate a maintenance dose. Same drug, but now we want a constant infusion rate to maintain that therapeutic concentration of 5 milligrams per liter. What dose? How you use this? Now you calculate this by using the elimination rate. So go ahead, pick up your zappers, and I would try C. Go ahead and answer. All right, this time it worked. Okay. The maintenance dose must replace that are being eliminated. It's very important. If you're going to have a steady state drug concentration, the rate of administration must equal the rate of elimination. And it takes about 4 to 5 half-lives to achieve the steady state of the drug. Okay, one more of these. What we want to do is the same scenario, but now you want to predict the half-life. Okay, yeah, Dr. Panyapong says, don't take notes. This is all in the handout. So just you listen, and then you should be able to read. The next slide should have the notes on it. So, okay. All right, so we want to calculate the half-life. The half-life is dependent on two factors. First off is the volume of distribution. The larger the half-life, the longer, longer the volume of distribution, longer the half-life. On the other hand, the clearance, the greater the clearance, the shorter the half-life. So half-life is proportional to the volume of distribution and in proportional to the clearance of the drug times special number. So go ahead, take a guess, and we'll see what we have. Okay, a lot of C's. Let's see what it is. B, 2.5 hours. Let's look. Again, half-life. The half-life is 0.693 times directly proportional to the volume of distribution, indirectly proportional to the clearance. So 2.5 hours. And again, it takes 4 to 5 half-lives to achieve steady state. And it doesn't matter what the drug is, as its first order, 4 to 5 half-lives will give you the steady state. Okay, drug X has a volume of distribution of 250 liters. Drug Y has a volume of distribution of 2,500 liters. Both drugs obey first-order kinetics of elimination and have the same clearance of 25 liters per hour. Which of the following predictions is most likely correct? Drug X is restricted to the body water, total body water. Total body water, anybody know? Guess? How many liters? Anybody? It's about 42 for a 70-kilogram person. I clearly have more than 42. Okay. But notice, these volumes of distribution are much greater than total body water. Therefore, they must be sequestered, either bone, fat, some other sequestration source. Okay, so drug X is restricted to the total body water. Given it the same dose, drug Y would have a larger plasma concentration at steady state. Drug Y has a longer half-life. Drug X is more lipid soluble, more absorbable. Drug Y is more likely bound to plasma albumin. Okay, let's take a guess. We always have one person that answers right away. Everybody else waits. Okay, a lot of people like C. Very good. Drug C has a longer half-life. Remember, how do we know? Half-life is directly proportional to the volume of distribution. So the greater the volume of distribution, the longer the half-life. Oops, let's go to the next one. And again, there's the calculation. Okay, now, pharmacodynamic question. Notice the figure above here. Relative to this figure, which of the following statements is true about A? What you have is a classic dose-response curve. Percent maximum response, and the concentration as a log of the agonist drug. B goes up and plateaus for maximum response. A plateaus here for a maximum response. So the question's potential answers are: drug A is a partial agonist. Drug A is more potent than drug B. Drug A is more efficacious. Drug A has greater potential for toxicity. Or drug A has greater bioavailability than B. Okay, let's go ahead and answer now. Okay, very good. C. Now, that's good. Drug A is more potent than drug B. Now, why is that one wrong? Okay, don't know what happened there. Okay. Why is it wrong? Potency is an indication of the dose of a drug that produces a given level of response. Okay? So you start off with a given level of response, and normally for pharmacology, that is the ED50, the effective dose that produces 50% of a maximum response. And so potency is not distributed vertically. Potency is distributed horizontally. And what you have to remember is that the potency is determined by the dose that produces 50% of the maximum response of the drug. Here, A is more efficacious, okay? But basically, the ED50 is going to be the same for these two drugs. So potency is an indication of the drug that produces 50% of the maximum response. It's not an indication of efficacy. Efficacy is distributed vertically. Potency is distributed horizontally. Okay, let's try another. 65-year-old female with edema receives a diuretic drug. Drugs X and Y have the same mechanism of diuretic action. Drug X is given in a dose of 5 milligrams, and it produces the same diuresis as 500 milligrams of the same drug. What does this suggest? The drug Y is less efficacious than X. Drug X is about 100 times more potent than Y. Drug X is safer than drug Y. Drug Y is more potent than drug X. Drug X is 100 times more efficacious than drug Y. Okay, let's answer now. Ooh. Okay, maybe it's time for a lunch. I don't know. That's not good. 6? 190s and 6? Ah! Not even C? Thank you. We had 7? All right. So it is B. All right. Now, I don't know, you must not like pharmacology, or they didn't talk to you about this, but whenever you have these doses, 5 milligrams produces the same level of effect as 500. This drug is more potent. He says nothing about safety. Safety is determined by the therapeutic index. Okay, let's move on. You discover that you have inadvertently given a patient a toxic dose of a drug known to be a competitive antagonist. What does that tell you? The agonist and the antagonist bind to different sites. The potency of the agonist is increased. The efficacy of the agonist is decreased. Sufficiently large doses of agonist can overcome the blockade. The antagonist possesses partial agonist activity. Okay, answer the question now. Hopefully more than 7. More than 7. Thank you. Okay. Okay, 30. Correct. D. When you have a competitive antagonist, the wonderful thing about competitive antagonists is that if you make a mistake, you can get rid of it by increasing the dose. Many years ago, we had a beta blocker called Nadolol, And when it first came out, a lot of people were poisoned by it, especially the elderly. Nadolol is a water-soluble beta blocker, and in the elderly, the kidneys don't function as well. And so they would give the elderly a normal therapeutic dose. And remember, normal doses are calculated in 20-year-old males, not in 80-year-old people. And so they would overdose very quickly and actually get very low heart rates, and some actually died from it. What people forgot was that you could give a beta agonist very high doses and overcome the competitive blockade. Now, people are afraid to do that because the dose that's needed is so high. But when you have a competitive antagonist, you can increase the dose sufficiently to overcome the block. Okay, let's look at some CNS drugs. And again, if you sign up for USMLE Step 1, these are the areas that you will be questioned on. And we'll try to touch on some of those in this section. Okay, during morning rounds, you hear of a patient admitted the night before with confusion, agitation, and restlessness. All that you know about this patient is that she's taken an NMDA glutamate receptor antagonist, memantine. What is the underlying problem with the patient? This one's probably just memory. Go ahead and answer it now. Okay. Nobody likes C. Okay. Alzheimer's disease. You got it? All right. Extra dessert for you at lunch. All right. Alzheimer's disease is thought to be associated with a decrease in cholinergic activity as well as changes in glutamate receptor function. So you can use two types of drugs, cholinesterase inhibitors and NMDA glutamate receptor antagonists. Okay, let's try some other ones. Now what we're going to do is we're going to put these next two questions. There are two questions that we'll answer using the same scenario. A patient who has a high abuse potential, complains of feeling restless and on edge, experiencing difficulty in concentration and sleeping. You diagnose a general anxiety disorder, a GAD, general anxiety disorder, and prescribe a drug known to be effective but with minimal abuse liability. Which one of the following would you go for? Alprazolam, bupropion, haloperidol, naltrexone, or paroxetine? Go ahead and answer now. I figure I'm going to get to an area that you guys know here eventually. Haloperidol? Okay. You just took C. Okay. Paroxetine. Paroxetine is an SSRI, a selective serotonin. Let's go ahead and move over here. Oops, sorry. Paroxetine is an SSRI. It's a selective serotonin reuptake inhibitor. And it can be used, a lot of times people use benzodiazepines, but if the patient has high abuse potential, you may not want to give them a benzodiazepine because of their abuse potential. So you can give them an SSRI instead. Now, haloperidol and naltrexone wouldn't do a whole lot, would not help, okay, at all. Haloperidol is a dopamine receptor antagonist, and it's used for antipsychotic, as an antipsychotic medication. Okay, after a few weeks, the patient complains of jitteriness, insomnia, sexual dysfunction, including aorgasmia. Which of the following would be appropriate alternative for her general anxiety disorder. Again, buspirone, clomipramine, clozapine, diazepine, or trazodone. So she's on an SSRI, but she's having problems. She has abuse potential. So go ahead and answer it now. All right, we have to talk. No. Now, diazepam is Valium, all right? This lady has abuse potential, all right? Now, you all are very, very young. I am very, very old, okay? But in the 60s, the Rolling Stones, you know Rolling Stones, singing group? My favorite group, okay? All right, Rolling Stones had a song called Mother's Little Helper, okay? And Mother's Little Helper was a song written about diazepam, because diazepam can be very habit-forming, okay? So, now this is, fine, wait a minute. You don't like volume of distribution. You don't like calculating maintenance dose. You don't like calculating the half-life. You may never use those again. They may or may not be on the exam, but I guarantee you, if you give diazepam to somebody with abuse potential, it's wrong. Step 1, Step 2, Step 3. I think that's right. American Board of Internal Medicine. I think it's wrong all the way, okay? Rest of your life. That's a wrong answer, okay? So, no diazepam, all right? Whoops. Buspirone, however, can be given in place of a benzodiazepine, and it is less abuse potential driven. The other thing to try to do, I didn't tell you this yesterday because I wasn't here, but when you look at a question and you look at answers, it is as important to know the wrong answer as the right answer. You should eliminate answers. If you look at an answer like diazepam and you say that's wrong, scratch it out, okay? And then move. It's as important to know that. So, and what I would recommend you do, that when you go home and you have these notes, when you review these questions, look up the wrong answers as well as the right answers. It's important that you be able to recognize which ones are wrong. If from those two questions, which we did together, alprazolam and diazepam have high abuse potential. They'd be very good for general anxiety disorder, but they have high abuse potential, and that was what the question was asking. Bupropion and trazodone are antidepressants. Clozapine, haloperidol are antipsychotics. Clozapine is actually an atypical antipsychotic, while haloperidol is a classical dopamine 2 receptor antagonist as an antipsychotic. None of these are used in general anxiety disorder. Clomipramine is an antidepressant used in obsessive compulsive disorders. And again, I think Dr. Somkit yesterday told you there are about 500 or 600 facts that you just sort of memorize. This is one of those facts, okay? OCD. Naltrexone, of course, might help with some cravings for alcohol withdrawing, but it is not anxiolytic. So paroxetine and buspirone are the only answer. So sometimes if you don't know the right answer, you can divine the right answer by knowing what the wrong answers are. Okay, 50-year-old female with a history of psychiatric medication presents with stereotypic orolingual and masticatory movements involving lip smacking and tongue protrusions. Which of the following is she most likely suffering from? Abstinence signs due to withdrawal of lithium, neuroleptic malignant syndrome, obsessive compulsive disorder, tardive dyskinesia, or Tourette's? Go ahead and pick the answer now. Okay, much better. Tardive dyskinesia. Do you guys have Harry Potter? Have you read Harry Potter? You have that book over here? You guys read that? In one of the books, Marty Boggs, he dresses up as Mad Eye Morgan, Mad Eye, what's his name? Mad Eye, whoever. But he's got a potion, so he's disguised. But his father recognizes him because he has tardive dyskinesia. And through the whole movie, he goes. That's called fly-catching behavior. And that oftentimes is seen in tardive dyskinesia. So, all right. And tardive dyskinesia can be caused by chronic blockade of dopamine 2 receptors. All right? So, oftentimes, people who are on antipsychotic medication of the dopamine 2 receptor antagonist type will show tardive dyskinesia and that fly-catching behavior. Okay, let's try another one. Which of the following drugs might be used to replace the current therapy? This person is taking a dopamine 2 receptor antagonist, which would potentially relieve the tardive dyskinesia, even though occasionally it is irreversible, but have minimal risk of other adverse effects. Go ahead and pick one now. Okay, time's running out. Oh. Somebody tell me that there was a solar flare that interrupted with the electronics in the room. I'll go with a solar flare. 2 people. Good. Try again, please. Now. Okay. Ah. Okay. Come on. Give it. Come on. All right. Much better. Wrong answer, but much better. That's okay. No. I'll take the wrong answer today. It's okay. Because when we take the test, we don't want the wrong answer, right? Better to make mistakes today and get the right answer when you take the test. All right, so what is the answer? Risperidone, extra dessert for this row right here. Okay. Okay, now what happened? Okay, now. Maybe I led you astray. No, maybe it was my fault. Because what we said is the tardive dyskinesia occurs when you block the dopamine 2 receptors. So, I think many of you said, hopefully, dopamine receptor antagonism causes tardive dyskinesia. Therefore, as good pharmacologists, maybe we could give a dopamine receptor agonist. And that would take care of the tardive dyskinesia. It would, but it will make them very psychotic, okay? Because that's their problem. They're psychotic. The other thing is that bromocriptine is not a good drug, okay? It's an ergot alkaloid, many adverse effects. So bromocriptine would not be a good answer. Let's look at some of the others. What about haloperidol? Haloperidol is the prototypical dopamine 2 receptor antagonist. So it is probably the worst of the group for causing tardive dyskinesia, so haloperidol is wrong. Well, how about thioridazine? Thioridazine is better. It is a dopamine 2 receptor antagonist, but a lot of times the extrapyramidal effects are not seen because it is also an antimuscarinic. Unfortunately, antimuscarinics don't have anything to do with tardive dyskinesia, and therefore you could still see tardive dyskinesia with thioridazine and haloperidol. That leaves us two answers: risperidone and clozapine. Both of those are atypical antipsychotics, which means much less dopamine 2 blockade, more probably serotonin 5-HT receptor blockade. And so both of these drugs would result in a lessening or possibly reversal of tardive dyskinesia while still maintaining antipsychotic effect. Problem is clozapine, I could do it here. Problem is clozapine, while it is as good as risperidone, where's risperidone? Up here, causes a granulocytosis, and so it is held in reserve for people who cannot tolerate other atypical antipsychotics. Okay, but not bromocriptine. Okay, patient being treated for Parkinson's disease also has benign prostatic hypertrophy. Which one of the following might be contraindicated? Now, I put this question up here because this one is tricky. You must read the question. Number one question, do not fight the exam. Number one question is, read the question and understand. Sometimes they're going to ask you for the opposite. So which one of the following would be contraindicated? Selegiline, levodopa, carbidopa, ropinirole, benztropine. Go ahead and answer now. Answer quickly. C is not the right answer. Okay, good. Benztropine. Very good. Now, why? Why is benztropine the right answer? Benztropine is an anti-muscarinic agent. And people with benign prostatic hypertrophy, if you block the muscarinics in the periphery, it's going to increase resistance to flow and make their prostatic hypertrophy worse. While it would do very good potentially in the brain, actually benztropine is probably a second or third string drug. Generally not the first drug you would use for Parkinsonism, but because of its anti-muscarinic action would be not good in this patient. The others would all be acceptable. Okay, let's try another one. Fentanyl, transdermal patches have been used postoperatively to provide transdermal analgesia. The most dangerous adverse effect of this mode of administration is cutaneous reactions, diarrhea, hypertension, relaxation of skeletal muscle, or respiratory depression. Go ahead and choose one now. Okay, somebody yelled out C, not this time. Respiratory depression. Fentanyl is an opiate, all right? The major, and look guys, the most dangerous adverse effect of an opiate is respiratory depression because they die, right? That's bad. Now, the other thing though is you could look at the others. Diarrhea, what would an opiate cause? Constipation. What about hypertension? What would an opioid cause? Generally, they're going to cause hypotension if they affect blood pressure at all. And relaxation of skeletal muscle, one of the adverse effects of fentanyl is increased tone, especially of the dorsal skeletal muscles. So those are all incorrect. Okay, let's try autonomic pharmacology. I was trying to warm you up with the CNS stuff because I know my medical students hate autonomic pharmacology. I love autonomic pharmacology, but don't like it. All right. We're going to talk about 2 questions again using the same scenario. And again, you will see this on the USMLE exams. They will give you a scenario and then they'll ask a series of questions. Farmers brought to the emergency department following exposure to an organophosphate insecticide. He is wheezing and shows signs of severe bronchospasm. Which of the following would not be consistent with organophosphate poisoning? Increased salivation, increased bowel sounds, urinary urgency, mydriasis, or skeletal muscle fasciculation. This question is a review of parasympathetic pharmacology. So answer now. Okay, all the autonomic experts, it's time. Okay. D, mydriasis. Okay, now, I don't know. There's somebody over here who keeps yelling out the answer. Don't listen to him. Okay? Not right. Not E. All right, so let's look at this. Have you guys ever heard of dumbbells? It's a way to remember some of the anticholinesterase inhibitor poisoning. D, whoops. D is for diarrhea or defecation. Again, acetylcholinesterase inhibitor, an organophosphate. What's it going to do to acetylcholine levels in the body? It blocks cholinesterase. So cholinesterase is not, acetylcholine is not being destroyed. So what happens to cholinesterase levels in the body, acetylcholine levels in the body? They go up. So acetylcholine levels are elevated. What does acetylcholine do? It hits muscarinic and nicotinic receptors. Therefore, D, diarrhea and defecation. And that M means muscarinic receptor. Urination. Again, the bladder constricts. M, meiosis. Meiosis is the constriction of the pupils. Okay? Again, acetylcholine stimulates muscarinic receptors on circular muscles of the eye, causing the meiosis. What would cause mydriasis? Obviously, if you block the muscarinic receptors, you get mydriasis, but what other system causes mydriasis? Sympathetic nervous system through alpha receptors. Okay, good. Bronchospasm, again, muscarinic receptors. Bradycardia, decrease in heart rate due to stimulation of muscarinic receptors. Excitation, okay, of CNS and skeletal muscle. This is going to be tremor and fasciculation of skeletal muscles and excitation in the brain. And those are nicotinic receptors. Remember, when you block cholinesterase, you do not get a selective effect. Acetylcholine will stimulate whatever receptor it finds, whether that's a muscarinic or a nicotinic receptor. Lacrimation. Any of the glands are going to be stimulated through muscarinic receptors. So lacrimation, salivation, and then finally sweating. Even though, if you'll remember, sweating is a sympathetic nervous system function. It is one of the few systems that actually uses acetylcholine stimulating a muscarinic receptor as the effector system. So dumbbells, you can remember acetylcholinesterase inhibition can give you all of those effects. Okay, the farm worker again brought to the emergency room after organophosphate insecticides wheezing. That is part of the increased bronchospasm and secretion of bronchial secretions. Which of the following combinations of drugs would be used to treat this farm worker? Atropine and epinephrine, epinephrine and bethanechol, atropine and pralidoxin, tubocurarine and atropine, or pralidoxine and 2-PAM. Go ahead and answer now. There's somebody over here who loves E. If you get to come to West Texas, you probably need to know the answer to this one. Very good. Atropine and pralidoxine. That's true. Actually, this question is actually a real scenario. When I was a graduate student in San Antonio at the Health Science Center there, they actually brought in a fellow who had fallen into a vat of organophosphate insecticide and had all of those symptoms. They gave the individual atropine and pralidoxine. Atropine is going to block the muscarinic receptors, and it's going to eliminate the meiosis, lacrimation, rhinorrhea, salivation, bradycardia, bronchospasm, bronchosecretions, acid secretion, increased gut motility, defecation, urination. So the muscarinic and sweating. The muscarinic receptor blockade will eliminate a lot of those adverse effects. The pralidoxime tries to regenerate the acetylcholinesterase. If you remember, organophosphates are non-competitive, or rather irreversible. They phosphorylate the cholinesterase, kill it, so acetylcholine levels continue to rise. If you can get the pralidoxime on board before the aging occurs, you can regenerate the acetylcholinesterase. If not, they have to wait until they make more. You end up, if you don't get it in time and you get respiratory paralysis, then you have to breathe for them. Okay, you can read that on your own. Same thing. All right, now the next 3 questions. 27-year-old woman presents with muscle weakness, including eyelid ptosis, slurred speech, difficulty swallowing. History shows the woman is being treated for a gram-negative infection with gentamicin, which is an aminoglycoside antibiotic. Following tests have been ordered: thyroid function studies, serum creatinine, electromyogram, and muscle biopsy. But the attending chides the resident, says, why don't you just give them edrophonium and see what happens? When they give edrophonium intravenously, they get their muscle strength back. All the other tests are normal. Okay, so the questions are, whoop. All right, you get that one. All right. This patient's underlying condition most likely results from, why don't I just give that one to you since you know it already? It's A, okay? People who have myasthenia gravis are very sensitive to the effects of aminoglycosides on acetylcholine release. So this is myasthenia gravis. Let's go to the next one. Aminoglycoside antibiotics create and exacerbate muscle weakness through inhibition of presynaptic release of acetylcholine, antagonism of the action of acetylcholinesterase, potentiation of the action of acetylcholinesterase, increasing turnover of receptors, slowing conduction of the action potential. Go ahead and pick one. Okay, we don't know. All right. Inhibition of presynaptic release. The aminoglycoside antibiotics block calcium access into the nerve terminal and inhibit the ability of the acetylcholine to release. The myasthenia gravis is an autoimmune disease attacking the nicotinic receptors, decreasing their numbers. So when you put together loss of receptors and loss of release, you exacerbate or expose the myasthenic state. Okay, let's try the next one. Primary treatment of this patient's condition should begin with an organophosphate, mefenamic acid, pralidoxime, pyridostigmine, or triorthocresyl phosphate. Go ahead and pick one now. Favorite number over here is E. Good. That's good. All right, let's move on. You guys, I think you know this one. Well, 19 of you know this one. Okay. Okay, an ophthalmologic examination of a 60-year-old man complaining of vision problems reveals increased intraocular pressure and optic disc changes and visual field defects. These findings strongly suggest primary open-angle glaucoma, for which pharmacotherapy is being considered. For the above patient is initially designed to open trabecular meshwork by contracting ciliary muscle. A useful agent for this purpose would be atropine, succinylcholine, pilocarpine, dexamethasone, or tubocurarine. Go ahead and answer that now. Good. That's right. You need a muscarinic agonist. Okay? Muscarinic agonist is going to constrict the ciliary body and pull the trabecular meshwork to increase efflux of the aqueous fluid. Injection of a pharmacologically effective amount of an anti-muscarinic agent like atropine may. Now, the beautiful thing about pharmacology is that if you know what the agonist does, you can predict what the antagonist will do. So, we're looking at an anti-muscarinic agent like atropine. So, will it increase bronchial glandular secretions, increase heart rate, cause paralysis in skeletal muscle, constrict pupils, or promote sweating? Go ahead and answer now. Okay. B, increase heart rate. Okay. Now, how do we know? Well, increased bronchial glandular secretions is going to be stimulated by acetylcholine through muscarinic receptors. So atropine is going to do exactly the opposite. It's going to have a tendency to dry up secretions. Paralysis in skeletal muscles. Paralysis in skeletal muscles is a nicotinic receptor function. We're talking about an anti-muscarinic agent. And while I know there's some debate, clinically speaking, it's hard to get enough atropine to give you an anti-nicotinic response. So that's generally not going to happen. I know in the old days, the Army used to give soldiers atropine, a large dose of atropine to carry into battle, so that if they got hit with nerve gases, organophosphate poisoning, that they could survive. They'd give themselves the atropine. In fact, atropine does a very good job of blocking all of the muscarinic side effects, but they're still going to suffocate and die in respiratory paralysis because it doesn't touch the nicotinic receptors. So a nicotinic function on the skeletal muscles, not going to happen. Constrict the pupil. That's what acetylcholine does. So if you give atropine, you could block that. Now, I'm under the impression that atropine lasts a long, long time, many days. So you don't want to be putting atropine into somebody's eyes to dilate them. They won't like you, and they won't come back to see you anymore because they can't see for a week, right? Promotes sweating. Okay, it is going to actually block sweating because sweating is triggered through acetylcholine stimulation of muscarinic receptors. So people who take an anti-muscarinic agent would actually have an increase in body temperature due to a decrease in their ability to perspire. Acetylcholine to the parasympathetic nervous system will stimulate muscarinic receptors. That would decrease heart rate. If you give atropine, you actually can increase heart rate, and atropine can be used in certain instances of bradycardia. Okay, terbutaline, brethane, or Bricanyl is administered to a woman in her 7th month of pregnancy because of uterine contractions that began during the previous week. Which effect can be anticipated? So the first thing we need to do is we need to recognize what terbutaline is. Terbutaline is a beta-2 agonist. So would it increase extracellular potassium, increase GI motility, decrease blood glucose and insulin, increase heart rate with possible arrhythmias, or constrict bronchial smooth muscle? Go ahead and answer now. Very good. Arrhythmias. Okay, now, those of you in the room that put E are saying, what's going on here? Terbutaline is a beta-2 selective agonist. It's going to stimulate beta-2 receptors. What are beta-2 receptors going to do in bronchi? They're going to squeeze it, or are they going to dilate them? You would give a beta-2 agonist to an asthmatic to help dilate their bronchial smooth muscle. So again, take the time to read and understand what they're asking. This is exactly the opposite, right? This would be something you would see with a muscarinic agonist. You're going to increase heart rate and potentially give arrhythmias, even though terbutaline is a beta-2 selective agonist. You're looking at two possibilities. One possibility is rarely do you give a drug just to stimulate the beta-2 receptors. You're going to give a drug to effect. And so sometimes you will, because it is pharmacology, you can exceed the selectivity and go into the other receptors. So even though people say, oh, this is beta-1 selective or beta-2 selective, you need to remember that you can exceed that and get a direct effect. You got to exceed it pretty largely. There's a second effect, though, that you should remember, and that is if you get significant systemic absorption, it will go to the skeletal muscle vasculature, and it will dilate the skeletal muscle vasculature, increase blood runoff into the skeletal muscle, and that will drop your diastolic pressure and total peripheral resistance. And who knows when you do that, when you drop blood pressure? Carotid sinuses pick it up. They tell the brain. The brain does not like anybody interfering with its blood flow, and it will send out sympathetic tone to stimulate heart rate and contractility and try to increase cardiac function. And so, a reflex tachycardia is also possible. Again, you're going to have to overcome, you're going to have to get a significant amount of systemic absorption, but you can see it. If you will go back in your spare time and look at each of these, you will see that they are the opposite of what might happen. All right, now, first thing, I just heard somebody go, ugh. That's not a good response. When you're taking the test, don't be frightened. Just read, okay? Anybody, you guys know how to do breathing exercise? You guys do yoga over here, right? Right, when you see a bad question, just, okay, whatever. All right, anyway, let's look at this one. Let's work through it. The circles represent the size of pupils of a patient's right and left eye. Make sure you know which is the right and which is the left. Both without treatment control, and 2 with different treatments. Treatment with tyramine, treatment with epinephrine. Now it helps to know what tyramine does for a living and what epinephrine is. Which of the following is compatible with the findings shown for the left eye? So what we're doing now, we're being directed toward the left eye. Without treatment, there's the diameter of the pupil. Treatment with tyramine produces a meiosis in the left eye. I'm sorry, no, my bad. Treatment of tyramine has no effect on the left eye but causes a mydriasis in the right. But when you treat with epinephrine, you get a mydriasis again like you did with tyramine, but in this left eye, you get an enlarged mydriasis, a greater mydriasis. So, what does that mean in terms of mechanisms? What is the drug that's being administered to the eye in the presence of tyramine, where it has no effect on the left eye, and with epinephrine, where you actually get a potentiation? Okay, which of the following is compatible? What drug might we be talking about here? Blockade of alpha adrenergic receptors? Blockade of beta adrenergic, not drugs, sorry, what effect are we looking at? Blockade of beta adrenergic receptors, blockade of muscarinic receptors, inhibition of cholinesterase, or sympathetic denervation. Okay, go ahead and pick one. Let's see what you think. Okay, pretty much everybody guessed. All right, let's see. What's the right answer? E. Sympathetic denervation. Okay, let's look. What does tyramine do for a living? How does it cause sympathomimetic responses? Does it directly stimulate receptors? Or is it an indirect sympathetic agonist? It's indirect. And what this says is that when the tyramine hit the right eye, it released norepinephrine and caused mydriasis. But when it hit the left eye, there was no norepinephrine, and so there was no mydriasis. With epinephrine, which is a direct agonist, it causes the mydriasis, but it caused supersensitive response because once you have a denervation of the sympathetic nervous system, you get a supersensitivity of the receptors. Okay. Now, another diagram. Now, and it is important to read the diagrams to understand what's going on. In the diagram, an unknown drug, X, is injected intravenously in 6 different animals. So each of these is a separate animal. Each one receives drug X at this point. The control animal is untreated here, and each of the other animals is pre-treated with a single drug as shown. So we're looking at blood pressure, systolic, diastolic, following the injection of drug X in the presence or absence of various treatments. From the data, drug X is likely to promote activation of an alpha adrenergic receptors, activation of ganglionic muscarinic receptors, activation of ganglionic nicotinic receptors, blockade of beta 2 adrenergic receptors, and release of vasoactive intestinal polypeptide. So go ahead and answer now. Okay. A. Oh, ouch. Now, let's walk through this. Why is it A? First off, when drug X was administered, it caused an increase in blood pressure. Hexamethonium, which is a ganglionic nicotinic receptor blocker, had no effect. So that tells you that this is not pre-ganglionic. It's not in the brain or in the preganglionic neurons or at the ganglia. Atropine had no effect, which is fine. Probably shouldn't. Reserpine. What does reserpine do for a living? Again, it depletes norepinephrine from nerve terminals. So when you depleted norepinephrine, there was no norepinephrine. There was no response. So this drug must be working through a different type of mechanism. Look at imipramine. What's imipramine do? It's an inhibitor of norepinephrine or biogenic amine reuptake. One would think that this might have actually potentiated the response had it been norepinephrine, which it did not. And phenoxybenzamine, an alpha antagonist, blocks both alpha 1 and alpha 2, totally blocked the response. So this answer here, this observation, tells you that alpha adrenergic receptors seem to be involved in this response. Based on that observation, drug X is most likely isoproterenol, norepinephrine, epinephrine, amphetamine, or angiotensin II. Go ahead and answer now. Okay. No, amphetamine. Okay, now, a lot of you liked isoproterenol, but what kind of a response would isoproterenol give you? Isoproterenol would give you an increase in systolic pressure because it's increasing the inotropic state of the heart. That would make sense. But isoproterenol will not increase diastolic pressure. Isoproterenol is a beta 1 and beta 2 selective agonist. In order to increase diastolic pressure, you're going to have to stimulate alpha receptors in arteries, and that didn't happen in any of these scenarios. So it could not be isoproterenol, especially if we realize that alpha adrenoceptors needed to be stimulated. Amphetamine, on the other hand, is consistent with the diagram. 1, when you gave amphetamine, there was no effect in the presence of reserpine. Amphetamine relies on norepinephrine release as an indirect sympathomimetic. There was no norepinephrine after reserpine. 2, imipramine did not potentiate the response because imipramine blocks the uptake of amphetamine into the nerve terminal because it uses that biogenic amine transporter. And 3, the norepinephrine that amphetamine should respond to, there was none in the, you could not see it because phenoxybenzamine had blocked the alpha receptors. So that's why it was not isoproterenol, because isoproterenol has no or little alpha stimulating activity. Norepinephrine and epinephrine. Norepinephrine does have alpha agonist activity, but why? And you could understand why phenoxybenzamine would block the response. But reserpine also blocked the response, and reserpine would not block the response of norepinephrine. Epinephrine is in that same category, so it had to be amphetamine. Okay, another one. Epinephrine is administered to an animal either by itself in A or in the presence of an antagonist B. What is the antagonist drug? Atropine, a muscarinic antagonist, prazosin, alpha antagonist, atenolol, a beta antagonist, labetalol, which is both alpha and beta antagonist, and reserpine, which depletes norepinephrine. What are we looking at? We get an increase in heart rate into control, an increase in systolic, and a decrease in diastolic, which is classic for epinephrine. In B, after we put on an antagonist, we still see a little bit greater drop in diastolic pressure. No real change. Well, there is an increase in systolic, but not an increase. And there is an increase in heart rate. So go ahead and choose which one you think is operative now. Prazosin. Okay, very good. 40% of you got the right answer. This is known as epinephrine reversal. Okay? What you've done is you've blocked the alpha receptors. And therefore, you see the beta-2 effect of epinephrine here. And you see an exaggerated increase in heart rate because when you drop diastolic pressure, you drop total peripheral resistance. You pick it up in the carotid sinus, the brain sends out sympathetic tone. So what you've done is you have blocked the alpha stimulating potential of epinephrine. Okay. Okay, let's do some cardiovascular. I got a feeling we'll do cardiovascular pharmacology, and I'm going to let you guys look at the rest on your own. So let's see how far we can get through cardiovascular. Again, USMLE lists the subject areas that you need to be familiar with. I'm hoping that when you go back and review these, you'll see that we've covered several of these areas. Very important. Now, I'm an autonomic cardiovascular pharmacologist, okay, so this is the area that I like the most. And I always tell my medical students that this is an equation to live by. You need to remember this. Mean arterial blood pressure is equal to cardiac output times total peripheral resistance. Now, actually, nobody in the whole world cares about mean arterial blood pressure except one entity, and that's our brain. Our brain calculates mean arterial blood pressure on a regular basis. It is the diastolic pressure plus 1/3 of the pulse pressure. And pulse pressure is systolic minus diastolic. So, the brain, I learned to calculate mean arterial pressure when I was 25. I didn't realize my brain had been calculating it in utero before I was even born. The brain is concerned with mean arterial blood pressure, and it tells the brain if it's getting enough of cardiac output. As clinicians, you're really going to be worried about cardiac output because that's what's going to determine function and life of your patients. So, mean arterial blood pressure is cardiac output times total peripheral resistance. The brain ensures sufficient mean arterial blood pressure through 4 mechanisms. Through the sympathetic and parasympathetic system, it controls heart rate or chronotropy. Primarily through the sympathetic nervous system, the brain controls inotropy. And when I think of inotropy, I think of calcium release to the contractile proteins of the cardiac muscle cell. The brain also controls preload, or venous return to the heart, and it does so by sympathetic stimulation, releasing norepinephrine, stimulating alpha receptors, constricting veins to push more blood back into the ventricles. Between the amount of calcium released on the contractile proteins and the preload, or the volume, which regulates Frank Starling's, you determine stroke volume. So cardiac output is a function of the heart rate in beats per minute and the stroke volume in milliliters or liters per beat. And when you combine those, you get volume per minute. So cardiac output is a function of heart rate, inotropy, and venous return to the heart. Afterload, or total peripheral resistance, on the other hand, is an arterial function and is determined by a number of factors. Sympathetic nervous system and the renin-angiotensin-aldosterone system all play a role in this. Okay, let's look at some antihypertensive agents. Again, you need to know the diuretics, renin-angiotensin-aldosterone inhibitors. We have a new one. We have a renin antagonist now, aliskiren. Sympathoplegics and vasodilators. So let's look at some of these questions. JS, an African American male with a blood pressure of 170 over 110 and a heart rate of 86 presents in your clinic. Drug of choice for initial monotherapy would be captopril, propranolol, verapamil, hydrochlorothiazide, or hydralazine. Go ahead and pick one now. Okay, no. Good for the D, people. Hydrochlorothiazide. Now, propranolol is a pretty popular antihypertensive agent, but it's important that you realize one thing. The African American population in the United States, their hypertension is almost always salt sensitive. All right? So African Americans do much better on a thiazide diuretic and not very well on a beta blocker at all. In fact, now the thiazides and even the chlorthalidone, which is a thiazide-like diuretic, are being used as sort of the first-line therapy for most hypertension. It's interesting, and this doesn't always apply, but oftentimes Caucasian male, young Caucasian male, often are hypertensive because of a hyperkinetic heart. They would do pretty well on a beta blocker. Also, ACE inhibitors are used, and to some extent verapamil. Hydralazine is really not used. It's a third-string drug. So, for African American hypertensives, you should always assume they are salt sensitive, and a thiazide would work well. All right, 62-year-old female is referred to a pulmonary medicine specialist by her family physician because of chronic dry cough. It's been unresponsive to medication. She has been taking captopril for hypertension for 3 years. What is responsible for the cough? This one, I want 196 answers. Everybody should know this one. Accumulation of angiotensin II, depletion of angiotensin II, bradykinin depletion, inhibition of bradykinin metabolism, or bronchospasm secondary to decreased angiotensin II epinephrine release. Answer now. Very good. Bradykinin. Remember that angiotensin converting enzyme is bradykinin metabolizing enzyme, right? So good. It's inhibition of bradykinin. Okay, an elderly 83-year-old woman is placed on an antihypertensive therapy and quickly begins experiencing orthostatic hypotension. Which one of the following medications could you prescribe to minimize this adverse effect? In other words, which one of these medications would have the least ability to produce orthostatic hypotension? Go ahead and select one now. Not too much response. Ooh. 7. Another glitch, maybe. You guys want to try it again? Can we try it again? All right. Well, at least we got more than 7. That's good. Am I in the way? Am I blocking? Okay. Awesome. There we go. Good. Good. Excellent. Nifedipine. Very good. Remember, old people, not old like me, but older people, are oftentimes volume depleted, maybe as much as 20% volume depleted. So anything that decreases venous return, whether it be dropping more blood volume, as a diuretic would do, or decreasing sympathetic ability to constrict the veins, will put elderly people at risk of orthostatic hypotension. Nifedipine is a good answer because it's a calcium channel antagonist that works primarily on arteries. Okay, 40-year-old Caucasian male with asthma, diagnosed with essential hypertension, is placed on a high dose of an antihypertensive medication. While taking the drug, his heart rate is approximately 56 beats per minute. He complains of tightness in the chest, difficulty breathing. He later claims to be depressed more than usual and to be having difficulty with sex. Of particular interest, he is particularly sensitive to orthostatic hypotensive effect of the medication, but has no sensitivity to cold. What drug is this patient taking? Is it prazosin, nadolol, pindolol, atenolol, or labetalol? Okay, everybody choose one now. Keep trying. Ouch. Okay. Of the 34 people, or 20% of the people in the room who voted, 38% think it's an alpha blocker, prazosin. 35% of you think it's a beta blocker. And 9% of you are correct. Now, before we go past this slide, look at what we've got. Let's think about it. Let's look at the evidence. 56 beats per minute. That's a beta blocker, right? Anytime you get that low blood pressure, it's a beta blocker. He's having difficulty breathing, all right? He's got tightness in the chest. So again, we're looking for some sort of non-selective beta blocker. He's depressed and he's having difficulty with sex. Again, this is looking at a beta blocker. However, he has orthostatic hypotension. What are we looking for? That's an alpha blocker. All right? So we have a drug that this gentleman is taking that is causing a number of beta blocker adverse effects and one that is an alpha blocker adverse effect. So what is he taking? Labetalol. And why labetalol? It is an alpha and beta blocker. It does both. Now, For those of you who are trying to remember what these are, any of these drugs that are OLOL, Nadolol, Pindolol, Atenolol, Metoprolol, Esmolol, any of the OLOLs are beta blockers, except for labetalol. And I think that the makers of labetalol stuck an A right there for me to remind me that labetalol is an alpha blocker and a beta blocker. Okay? The other drug that is available is carvedilol, which is also alpha and beta blocker. So what this did is it combined adverse effects of a beta blocker with adverse effects of an alpha blocker. All right, let's try another one. That one didn't work too well. Using the above vignette, this fellow again, which monotherapy would be a most appropriate? Heart rate is low. He's having bad dreams. He's having problems with sex. And he's having orthostatic hypotension. So what drug might you change him to? Enalapril, propranolol, prazosin, hydralazine, or labetalol? Go ahead and pick one. Now. Go ahead and pick it now. Keep pushing. Push, push, push. Good. Enalapril. Enalapril does not lower heart rate. It does not cause depression, and it also has little effect on sexual function. And other than volume depleted patients, it will not cause orthostatic hypotension. So that's good. Okay. Let's do a quick review of some of the anti-hyperlipidemic drugs. There are 5 that we can deal with. Many years ago, when I was a young graduate student, a young assistant professor, I used to tell the medical students that when I taught them the hyperlipidemic lectures, that of all the lectures in pharmacology, if they had to sleep, that was the lecture to sleep in, because we had no drugs of any value. They might change cholesterol 10, 20% at max. Not much of an effect. Today, though, with the statins, we now have drugs that will decrease cholesterol 40 to 60%, and that's pretty good. Okay, so how do the drugs work? Let's start with the statins. Again, the statins block the rate-limiting enzyme for cholesterol synthesis to decrease elevated cholesterol synthesis, which is a primary problem. As we grow older, we make more cholesterol. Niacin and gemfibrozil are primarily targeted at triglycerides or VLDL and not necessarily towards cholesterol. Not much of an effect on cholesterol at all, but both of them can increase to some extent HDL. And then cholestyramine and ezetimibe. These both are essentially non-absorbed. They work in the gut. Cholestyramine binds cholesterol and carries it out so that it's not absorbed. And ezetimibe blocks lipase in the gut, prevents metabolism of the lipid so that it can be absorbed. So again, the lipid is excreted. So we have a 45-year-old man taking simvastatin for hypercholesterolemia. Cholesterol level remains above the target at maximal doses. So they've given them as much as they can, and they're not getting their target dose. They want to add cholestyramine to this regimen. What drug-drug interaction can occur? Combination will not lower cholesterol more than either drug alone. The combination causes elevated very low density lipoproteins. Cholestyramine can inhibit GI absorption. Simvastatin is a direct antagonist of cholestyramine. Go ahead and pick one now. What do you think is going on with this fellow, potentially? Come on. Everybody push, push, push. Even if you want C, push C. C's good. And it is C. All right. You never want to give the statin and the cholestyramine at the same time. Remember, cholestyramine is a binder, and it will bind vitamins and statins in addition to cholesterol. So if you take them both together, you don't even get the beneficial effect of the statins. It's going to run through. Okay? Let me know, and I'll stop when you guys want me to. Another 5 minutes? Okay, lunch is 5 minutes away, and then we'll stop. Mechanism of action of organic nitrates, nitroglycerin, in the treatment of angina is increased intracellular calcium in coronary vessels, decreased alpha-adrenergic stimulation in cardiac muscle fiber, increased intracellular cyclic GMP, intrinsic contraction of cardiac muscle, direct cardiac beta-1 receptor stimulation. So we're talking about nitroglycerin and angina. Everybody pick one. Now. Sir. The now is important. Keep pushing. Push some more. Very good. All right. So you guys, you got the biochemistry down. That's good. All right. I want you to remember, well, let's see. I want you to remember that when the angina is a result of a fixed lesion, if you think about it, the coronaries dilate to provide as much oxygen as the heart needs. So when you increase cardiac work, the coronaries are going to dilate to provide the oxygen to sustain that work. When there's a fixed lesion, as in effort angina or chronic stable or classical angina, the coronaries are already dilated. Okay? If you think about that lesion in the artery, in the coronary artery, it's like having glue squirted in there. That coronary cannot dilate around that lesion. But distal to the lesion, the coronaries are already dilated to try to allow as much blood to get to the heart as possible. So when someone has chest pain and effort angina, the problem is that their delivery of oxygen is inadequate to support the amount of heart work. Nitroglycerin does not dilate coronary arteries in effort angina. It dilates veins, peripheral veins, and decreases preload. When you decrease preload, you decrease cardiac work. So all of the drugs that we have now for effort angina work by inhibiting the heart's ability to do work. They all decrease cardiac function. So that if this is all the blood supply you can get, you must lower cardiac work so that now you can supply adequate blood flow. So nitroglycerin in effort angina does not dilate the coronary artery at the lesion. It dilates peripheral veins to decrease preload, decrease venous return, decrease stretch, decrease stroke volume, decrease cardiac work, decrease oxygen need. Okay? The only time that nitroglycerin is going to work on the coronaries is if there is a coronary vasospasm around the lesion. Then you can get a direct effect. But it has to have a spasm component in the coronary. Okay, quickly, in terms of systolic failure, the drugs that we have for treating heart failure, red hearts, and this is mine, I apologize, it's not in the notes, but red hearts, all red hearts are healthy hearts, right? Purple hearts, they're not dead, but they're not doing great. Yellow, every yellow heart I've ever seen is dead, okay? So, red is improved survival in heart failure. Purple is systematic relief, but not improved survival. And yellow can actually be bad or increase death. So for heart failure, for over 200 years, digoxin and cardiac glycosides have been the treatment of choice in heart failure, and we found out we don't improve survival with dig. Symptomatic relief is very good, but no improvement in survival. So, ACE inhibitors and angiotensin receptor blockers improve survival. Spironolactone, an aldosterone receptor antagonist, improves survival in heart failure, as do beta blockers and a combination of hydralazine and isosorbide dinitrate. Diuretics, glycosides, and beta agonists in decomposition can improve symptoms, and alpha agonists, calcium channel blockers, and phosphodiesterase inhibitors like milrinone should be avoided on a basis. And this you might just want to memorize if you're not familiar with it already. I think I'm gonna let you do this one on your own. Okay, let's jump ahead. Let's see. Whoops. Rats. Okay. Well, we'll jump ahead of that one too. Now, this question is I don't like. This question was actually on a step 1 exam, and I would have trouble because the question is the vasodilator of choice in patients with congestive heart failure is, and the answer is captopril. To me, captopril is not a vasodilator. It's an ACE inhibitor. Okay? But oftentimes you've got to watch what you're doing. Captopril is considered a vasodilator because it blocks angiotensin-converting enzyme. That prevents angiotensin II buildup, and that eliminates a vasoconstrictor. So the end result is vasodilation. All right? I'm going to jump through these. Ready? One more. Last one. Okay. 58-year-old woman. Okay, so I want everybody to press a button. All right. 58-year-old woman presents with atrial fibrillation of recent onset. Resultant ventricular tachycardia produces heart failure. Which one of the following will have the greatest potential to convert atrial rhythm back to sinus rhythm? Verapamil, esmolol, and we know what esmolol is, right? OLOL. Adenosine, digoxin, or abutolide. Go ahead and pick one. Now. Okay, I thought I'd get a record. Okay, no. Butylide. Okay, now, what is the trick to this question? When you're dealing with atrial fibrillation, the problem is the ventricle is driven too fast. Too much heart rate, you don't have enough preload, stroke volume goes down, cardiac output goes down, and you have failure induced by the rapid heart rhythm. There are two ways to address the problem: rate control, rhythm control. As far as I understand to date, based on the literature, there's not necessarily an advantage of rate over rhythm or vice versa. But you have to decide which one to do. If you decide to control rhythm, what you're saying is you want to eliminate the atrial fibrillation or tachycardia. You want to have the sinus node drive the heart. You want to revert the patient to sinus rhythm. The only way you can do that is to break or convert the atrial arrhythmia. And abutolide will do that because it is a class 3 potassium channel antagonist. The atrial action potential is very narrow. And when you prolong the action potential duration, what you do is you increase the time that the atria is refractive to further stimulation, and so as those beats keep slamming into the atria, they're broken, and you allow the sinus node to reactivate. Now, the data would say that this is about 60% effective in breaking the arrhythmia. Unfortunately, the older the patient, the bigger the atria, the less chance of sustaining sinus rhythm. Rhythm control. What about rate control? Rate control is when you decide you don't really care about the atrial rhythm, you're only worried about ventricle. And so what you do is you do not try to break the atrial arrhythmia, but rather you try to control the rate at the level of the AV node. Verapamil, calcium channel blocker, esmolol, an intravenous short-acting beta blocker, adenosine, and digoxin all could be used to control the rate. However, esmolol and adenosine are very short-acting and would not be even for rate. Verapamil and dig, however, could be given to allow the atria to beat at whatever rate they want, but control the number of impulses getting into the ventricle, thereby allowing better preload, better contraction, and better stroke volume and cardiac output. Okay, we'll stop there. I'm going to be here this afternoon as the moderator, so if you look ahead and you have questions, we can talk about them during the break. Thank you. Oh, Krap Kun Krap.
We have time.